15331. And then main equals will be 15333. What I'm going to do is ask Sheldon to rejoin us in an hour. Maybe you're like hit like a noon hit here. Okay, so that okay.
Perfect.
And I mean, the only comments I have to make is this is an amazing piece of work for a lot of reasons. It's clinical trials in cardiac arrest are just really, they're just almost impossible to do because I think the work, if all the other variables, whether it's ventilation or what's the word I'm looking for, ventilation, CPR quality, all that could be controlled for better. The results here would be even probably more robust. If you have a really strong outcome here in any of these cardiac arrest studies, because I've gotten to mistrust the ones that don't show any difference because of all those confounding variables. So this is very cool. Now, one of the advantages you have here is you are dealing with ventricular fibrillation, which means that there are more cases are early on, they're witnessed, et cetera. That helps out a whole lot to help you achieve those goals, just like the ALP study did. And so I think that this is going to be, it's going to be a game changer, I believe, but, what do I know, right? So we'll see.
Yeah.
How's that for? That okay for stretch?
Yeah, no, but it's interesting. How long do you think it'll take? I guess this will be one of my questions. How long, or if will the guidelines change formally because of this study? And that's really the question, because oftentimes, even though we've been doing this for a couple of years now, you find that the rest of the country won't change to it for years unless it's formally changed.
It'll probably be done pretty rapidly, like 10 years from now. Okay, so we'll see. So, hey, but I think it'll change earlier. But that's the other thing is, remember, and I hope I'm not getting too inappropriate here, but I just remember there was a comment by a certain person that said, if it's good enough for 60 million people, that's why the Eagles were just 60 million people we were covering. It's good enough for the president of the United States. So the point is, I think with enough, if you have enough people doing it, if, for example, if all the Eagles, then you got it for about a third of the U.S. population. That's a de facto.
Yep.
I made it.
Hey, Paul. Okay, we got Shell on, so it's 11:03. Shell, we were just kind of talking about your study before you got on. So.
I love it.
All right.
All right. So we said some good things about it, just so you know.
Thank you, Paul. Yeah. I'm so sorry for being late, guys. Really apologize.
No, we'll blame Bill Gates. Don't worry.
I'm going to be sending you a link, and I want you to see if you could do a reprise on this, a little shorter, but in about an hour from now, if that's okay. All right. That's for the main Eagles group, okay?
Yeah, no problem at all.
All right,
I'm going to open my screen share, I guess, eh?
Yeah, do that.
What's that A thing? It's Canadian, I think, so whatever. So,
you got it?
Okay, so that's give me is 15331, everyone, and I'll shut up for a while. Peter, see ya.
Awesome, thanks, Paul. Shell, you want to go full screen with your slides? That'll be good.
Is that it? Can you see it now?
I can see it, but we see the left column of the other slides. So just say play. Say play from the beginning.
You're like
top left.
Oh, you're in edit mode. So just the thing that says it looks like a screen.
Yeah, mine doesn't show me that. Okay, what do I show? Screen. What do I do with screen?
Well,
I'll tell you what you do. Go to where it says PowerPoint on top and say it says view. Sorry, it says slideshow. You see where it says slideshow?
Yeah.
Now, if you go to the left, say from beginning. There you go.
You okay?
Nope.
You got me now.
You know what? We'll take it like it is, because I don't want to delay it anymore. We see the slides, but we see your other slides too. It doesn't matter. We see it really well.
Okay. That's
all right.
easy.
So, yeah, exactly. So listen, we have a great show today, and we've been waiting for this one for quite a while. And Shel Cheskes is, obviously we all know him very well. He's been on our webinar twice from Sunnybrook up there in Canada. And Shel underwent a huge undertaking for for this particular study. It was published in the New England Journal. He presented at the AHA in Chicago last week, and he was kind enough to come and give us the hot off the press overview of it. So without any further ado, Shell, welcome back to the Florida EMS webinar, my friend. Take it away.
Thank you so much, Peter, and thanks. I always love speaking to the Florida group. You guys have been very supportive throughout the trial, and I've had so many requests to speak. I'm really happy that the Florida one is one of the early ones. So going to be really nice today because I'm going to have a couple slides that we've never shown before for people, so I think they'll really enjoy it. So yeah, so again, thanks for allowing me to present the dose VF cluster RCT. Following sort of my disclosure slides and my research funding slides. So certainly would love to acknowledge all the co-investigators, many. Yeah.
I'm going to stop you because your slides aren't changing for some reason.
Oh man, they're changing.
I know, right? It's, oh, there you go. Now it's changing.
Are you changing now?
Yep.
Okay, let's
whatever you just did there, keep doing that.
Okay, let's see. Now I can't find my slides here.
You know what? You unshared it, so share it again.
Yeah, but I don't have the slide deck up here though. Okay, one sec. I got to get this right up again. Okay, Pete. Sorry, Matt.
Yeah, no worries. Yeah.
Buddy, this is Teams, man.
I know.
Okay. Whatever I got Teams going, there's something going on. Okay, come on, baby. Can you see me?
Okay, here it comes. Okay.
How about now?
We see slide number 1.
How about now?
Yeah, but we still see slide number 1.
Okay, I'm on slide 2. Okay,
yeah,
how about now?
Nope.
Nothing.
Do me a favor on your PowerPoint, at the very top of the PowerPoint, like at the top bar, do you see it says slideshow?
Yep.
Like above that, if you click on that, do you see it says setup show?
Yeah, setup slideshow, yeah.
Yeah, if you click on that, and then it says browse by an individual window. Click on that.
Yeah.
Yeah, and I say okay.
Yeah.
Okay, and now say from the beginning. Yeah, click there.
How about
now? Yeah, now you go. There you go. All right, you're good. You're good.
Okay. Total insanity. Okay. You guys seen everything? You seen everything, Pete?
Yeah. We're good. Yeah, go right ahead.
Okay. So yeah, just to the acknowledgements for sure, all the co-investigators, many were in Chicago, but for me, really, the 4,000 paramedics that we trained in the dose VF RCT, those are the real people I'd want to trace. I don't think I've ever had a study where the paramedics embraced the research as much as they did in dose VF. And really, if I had my choice, these guys would all be co-investigators in the study. Certainly by way of background, many patients we know remain in VF after multiple defibrillation attempts, but double sequential and vector change defibrillation have been proposed as alternative therapeutic strategies, yet really there's no high quality evidence to support or refute the use of either strategy for refractory VF. And currently under AHA, ILCOR, and ERC guidelines, double sequential external defibrillation is currently not supported. The research question we wanted to answer were, among adult patients presenting in refractory VF during out of hospital cardiac arrest, does double sequential or vector change defibrillation result in greater rates of survival and hospital discharge compared to standard defibrillation? The study itself was a 3-arm cluster randomized trial with crossover. It occurred in 6 participating EMS agencies in Ontario, Canada. The trial ran for just over 4 years, inclusive of an internal pilot feasibility study that was previously published. The trial was paused for 6 months due to COVID in 2020, and the DSMB recommended halting the trial on May 18, 2022, due to COVID-related operational challenges at the participating services. Survival and hospital discharge was our primary outcome. Secondary outcomes were ROS, VF termination, and neurologically intact discharge with a modified Rankin scale less than or equal to 2. When we really designed this trial, we really wanted to focus both on the vector and on the energy, because if either of these interventions work, we wanted to understand why it worked. Was it vector, was it energy, or was it perhaps a combination of the two? To be included in the trial, the patients had to present in VF or pulseless VT. They received standard ALS therapy if available, and they had to have a minimum of 3 successive shocks given and be in VF at the 4th rhythm analysis. So this is very, very important and very different from other studies. For patients to be included, they had to go VF, VF, VF. Anything other than that was excluded from the trial. The pads for the first 3 shocks were always in the standard AL position. After 3 shocks, the patients were then randomized to one of 3 defibrillation strategies. The first one, where the pads simply remained in the standard AL position as they were for the first 3 shocks. The second randomization, where the pads were removed from the AL position, placed in the AP position, otherwise known as vector change defibrillation. And the third strategy involved bringing a second defibrillator, having the pads placed in the AP position, in sequential shocking by 2 defibrillators, otherwise known as double sequential external defibrillation. Our paramedic training was really standardized. Both ALS and BLS medics received standard in-person training, both didactic, video, and simulated scenario on vector change and double sequential pad applications. All cases were reviewed by local PIs with feedback to the paramedics on both study compliance and protocol performance. And we found this was really key to further getting the buy-in from the paramedics that they had this close relationship with the PIs during the trial. All the patients were analyzed based on randomized treatment assignment, or ITT. General linear models with log link and binomial distribution accounted for clustering of the patients within each service, and we adjusted for age, sex, and bystander CPR. Outcomes were reported as adjusted risk ratios with 95% confidence intervals, standard defibrillation as a reference. When we look at our consort diagram, you'll see that we assessed 450 patients for eligibility, of which 405 were enrolled in the study, nicely balanced between standard, vector, and double sequential, as you'd expect from a cluster randomized trial. Remarkably, given the complexity of the trial, 80% of patients received the randomized allocated defibrillation strategy. When we look at the demographic characteristics, this is bad news for us males out there. 84% of males overall made up the dose VF cohort. So this is much more common in males than females. Our rate of bystander witness and bystander CPR were quite high, as well as public location as the location for the cardiac arrest. One thing that was a real concern going into the study, and because I'm quite anal about high quality CPR, was could you do high quality CPR if you're randomized to vector change or double sequential? And what we see in this slide is regardless of the arm that the patients were randomized to, paramedics provided guideline compliant high quality CPR throughout the trial, which is really remarkable given some of the challenges of the interventions. When we look at other characteristics, when we look at amount of drug given, whether it's antiarrhythmic or epinephrine, time to antiarrhythmic, time to epinephrine, time on scene, these are all very equally displayed between the 3 groups. You may see that the mean number of shocks to first ROS is very similar in all 3 arms, but remember, in vector and double sequential, they required a minimum of 3 shocks to actually be enrolled in those arms. So it really was 1 or 2 intervention shocks that were used to get ROS in those patients who got ROS. So these were patients who required a lot of these extra intervention shocks. If we look at our unadjusted outcomes, we see that survival to hospital discharge in the double sequential arm was 30.4%, 21.7% in the vector change arm, and 13.3% in the standard arm. But really, unadjusted doesn't mean much in a cluster randomized trial. When we look at the adjusted results, we see that double sequential was superior to standard care for all primary and secondary outcomes of the study. Vector change was superior to standard defibrillation for VF termination and survival to hospital discharge, but not for neurologically intact survival. First of all, this is really the first ever randomized trial exploring alternate defibrillation strategies for refractory EF. As we noted, double sequential was superior to standard defibrillation for all primary and secondary outcomes, while VC defibrillation was superior for VF termination and survival to hospital discharge. I think what's more important to note is we did a number of sensitivity analysis, and double sequential found very consistent findings among multiple sensitivity analysis, which we did not see in the vector change arm. The strength of a trial is really its cluster crossover RCT designed high quality CPR regardless of the intervention group. We included patient important outcomes with almost complete outcome ascertainment, so it was very little missing data for primary outcomes. We couldn't blind the paramedics, obviously tough to blind double sequential, but those assessing the outcomes and survival and neurologically intact survival were blinded to treatment allocation. We feel that the study has high generalizability because it occurred in both urban and rural settings. Both ALS and BLS paramedics use both Zoll and Stryker defibrillators. And I think the important for the defibrillator manufacturer is, despite all the hurrah about defibrillator damage and the potential using our sequential technique of double sequential external defibrillation, no defibrillator was ever damaged during the trial. When we look at the limitations, clearly it's enrollment. So COVID-19 pandemic impacted participant enrollment and trial protocol, resulting in early termination as recommended by the DSMB. I think when you think about that limitation, you need to realize that many styles chopped completely during COVID-19. The paramedics actually did this trial for 18 months during COVID-19, and I can talk about the stop later on, but it really was quite amazing that they did that long during the pandemic. Early termination, we all know, has the potential to overestimate the effect size, but the findings, particularly for DSED, were consistent amongst multiple analysis. Protocol compliance, 88%. You may think that's not perfect, but really for a real-world pragmatic study, we think it's excellent. And there was no collection of ED or in-hospital care, certainly in time for our publication in New England. And we'll show you some other stuff here today. So I think when you see these results, the question is, what is really the biological plausibility of our results? Why should vector or double sequential really work? And when you think of vector change, really, I think you need to visualize the position of the left ventricle. The left ventricle is really a posterior structure. And when you look at defibrillation using standard AL pads, look what happens. And this diagram is fantastic. As people talk about, well, maybe the pads are in the wrong position. This is a very lateral pad. And what you can see with that is you miss 50% of the ventricle with this pad placement. Yet, when you go to vector change, you actually pick up a greater proportion of the ventricle that was potentially missed by the standard AL pad. We think that in double sequential, you get a more homogeneous distribution of current across the ventricle. But the other thing is we saw a consistent 15 to 20% drop in impedance in the AP plane for vector change and the AP plane for double sequential, suggesting that both interventions are in fact applying a greater amount of current, which is really what's important during these two interventions. Some of the slides that I've never shown before are here. If you look at MRS, so modified Rankin according to treatment allocation, what you'll see is that of those who survived, 85% had a very, very good modified Rankin scale, a little bit lower in vector than double sequential and standard. And if you tease it out a bit more, look at the MRS scores for double sequential. How many had MRS scores of 0, 1, or 2? So you can see that's where the big difference in the neurological intervention appears to be. One of the questions was, were people perhaps in the arms getting differential rates of angiography or PCI? We did not have this in time for a publication, but you'll see here that angiography was very, very consistent across the arms, as well as a delivery PCI. So it wasn't like one arm was getting more of this intervention than the other. This was very consistent amongst the group. What's very interesting is look at the group. If you survived the hospital admission, those who had STEMI had high rates of angio and PCI, and correspondingly high rates of survival. But what's remarkable is even if you had no evidence of STEMI on an ECG, you'd expect your angio and PCI rates to be lower, but even they had a very high rate of survival. So I think that's important to take. Here, I think, is a really incredible slide. Remember, I mentioned that I said if the drugs were available from an ALS point of view. So here we had about 8% of the population with BLS care only. So no IV, no endotracheal tube, no antiarrhythmic, no epinephrine. And even in BLS care only, the survival to hospital discharge was 50%. It makes me think, forget the drugs, just give me another defibrillator. So I think this is a really, really intriguing slide. So in conclusion, double sequential was superior to standard defibrillation in this trial for all primary and secondary outcomes. Vector change was superior for VF termination and survival to hospital discharge. We feel that both strategies should be considered early in the management of patients in refractory VF. We also feel that the double sequential outcomes were much more consistent amongst multiple analysis, but vector change seems to be an alluring strategy in places with only a single defibrillator in rural EMS agencies. We really thank the New England Journal for reviewing it, a very intense review of our paper and its publication. And yes, in Chicago, I was a little under the weather, as Peter mentioned, as my daughter got married the night before. So I flew out at 6 in the morning to get to Chicago, and probably didn't give the talk quite as nicely as I hope I'm giving it today. So thanks so much, everyone, and happy to take any questions.
Wow, Shell, first of all, congrats on your daughter's wedding. Amazing. She looks amazing. I don't know about you, but she looks really good. No, but I know other people have some questions. I know other people have some questions. Yeah, exactly. I know other people have some questions, but the one I have for you is, tell us about some of the challenges in running this trial. I mean, I know that it's a big trial. It's a big area, but like, just take us through some of the challenges in running a big trial like this.
Yeah, so I think the biggest challenge actually was just getting out of the gates. So you remember in my slides I showed you that we used both Zoll and Stryker defibrillators, but remember, Stryker had a letter given to almost all their customers that if in fact they did DSED and damaged a defibrillator, they wouldn't honor the warranty. And that, to me, even to this day, keeps anyone who's interested in DSED, keeps them on the block, right? So we had to go to our chiefs and say, hey, we know about this letter, and they knew about the letter. They came to us, and we said, from our EPS experts, so we had Paul Dorian, we said, using sequential techniques, we don't think that you can ever blow up a defibrillator doing that, and they agreed to take part in the trial. But that was a big piece, or else we wouldn't even got off the ground. The second thing is you run a trial and you think it's almost like an ivory tower. They're going to give 3 shocks, and then the 4th shock is going to be an intervention shock. So people say, well, why did 50 people not get the randomization they were allocated to? Well, you know what? That's real life. And if there's paramedics on the call, we ran cardiac arrest in washrooms and toilets, on buses. Sometimes you just can't get that the change in place on the 4th analysis. So patient would get a standard shock, they would terminate VF, and then the patient wouldn't get the randomization, because as soon as VF was terminated, that was the end of that randomization. So that's just real life in which paramedics practice. The last thing, and probably one of the more frustrating things, was COVID, right? So COVID comes in, we had to stop. Most people, as I said, stopped everything. But in COVID, what happened, and the reason we had to halt the trial, or we decided to on the basis of DSMB, was at that point in time, we had 75% of our workforce. Of that 75%, either they had COVID or were off with COVID. The vast majority were sitting in emerge departments with offload delay. So what happened was, the key to this study is getting an intervention early. Paramedics were now showing up on scene after 5 fire shocks were given. Like, that's unheard of in our system, right? You get 1 or 2, never 5. So in fact, you couldn't give the intervention. So by that point, what you're actually comparing is standard to standard. because it couldn't get the intervention shock. So it's very, very important for people to understand we stopped this trial not because of superiority, because we didn't know the results. We stopped it because of feasibility. So I think that's really an important differentiation.
Very well said. Paul, go ahead. I know you have to leave in a few minutes, but go ahead.
Yeah. So there's 3 points I wanted to make. One is to really congratulate you on this, because it's almost impossible to do a clinical trial. Fortunately, you had a good subject. VF meant that you're getting there relatively early with the patient. But there's so many confounding variables, like the quality of CPR, like the ventilation, and you guys were keeping better track of that because of all those confounding variables. And the fact that you had your PIs out there with the medics is an important thing that people forget. And it wasn't done very well during the ROC. And so thank you so much for doing this. And it's a contribution. I mean, this in itself is just a victory, although a rare one, on cardiac arrest trials. So that was number one. Number two is that what I wanted to point out is that I'm almost, of the thing that go even earlier, maybe even after a second shock, to go right to this. And a lot of us are already putting the pads on the back just coming in, especially if we're going to put on a Lucas or whatever, and this helps support that. So thank you. But one of the things I do want to say, the term double sequential is a little bit, I got to put that in context. When I first talked about that, I was describing, because I'd learned so much from all these, physiologists that showed me about the VF, and they had to deliver the shock within 20 milliseconds. And they were showing that when you try to do it with 2 fingers at the same time, you're really not simultaneously doing it because there's such a small area. So I said, oh, so it's like a double sequential, whatever. And so when I go and talk about that at national meetings, then it ended up being adopted. All I'm going to ask is, I was going to say, is if there is a way, not that it's out on paper that way, but if there's a way to sort of change the title of what we call this, would be a little bit better. Like, for example, a duo vector or something like dual vector, defibrillation would be a really good thing. By the way, years ago, Joe Ornato did these cool studies in the lab where he had 80 different ones on at the same time. You can get away with a lot less energy, and it worked out. But because everybody thinks of VF as being this sort of chaotic random, but there's really movement around the heart, and you're more apt to pick things up this way. So I love the fact that you did the vector change alone. That was very cool. So thank you so much. Okay, I'm Paul Pepe, and I approve this message, right?
So Paul, but that brings up a good point that maybe Shell can explain to everyone, that you guys don't push the button at the same time. In the paper, you describe it. Can you take us through it real quick?
Yeah, no, that's very important. I think that's a critical piece of this. So it's the difference between animal lab and real life. Okay. So right. Many of the naysayers of double sequential would tell you that you have to press a button within a very specific time frame, 75 to 125 milliseconds for double sequential in the animal lab to be successful. So because you can't do that as a human, it can't be successful. But here we are a number of years later. We did it sequentially, and our median time was 500 milliseconds. So what that tells you, you press button 1, button 2 as quick as you can. So 500 milliseconds, we've done the timing on this. This will come out as a secondary paper. But what it tells you is that in humans, this does not correlate to the same information we got from the animal models. Right. In humans, 500 milliseconds seems to work, whereas, again, the naysayers would say it's impossible. And as I said, here we are today. So it's 2 quick pushes, and it does not need to be simultaneous. The reason we didn't do simultaneous is there is a minuscule risk, if you do it simultaneously, of damaging the motherboard of the second defibrillator. Now, that's only been described to me in one case where someone did synchronized cardioversion during double sequential for pulseless VT. So that's the case that everyone talks about. But the risk, if you do sequential shocking, there's essentially 0 risk to damaging the defibrillator.
That makes sense. Okay.
That's
how about we go to...
Okay, thank you so much.
Thanks, Shell, on that one. Let's go to Dr. Kim Landry from the Panhandle. Go ahead, Kim.
Hey, this has been so fascinating following your research for the past couple of years. And my question is, would there be any benefit to adding something like esmolol to quell the electrical storm just ahead of the double sequential or vector change?
Yeah, so Kim, that's a great question. And I'll tell you, when I came to Chicago, there was an individual giving a talk on esmolol. And he was unable to see a benefit through esmolol, and the reason was 20% of the patients got double sequential. So sometimes when you do that, you're not really sure where is your benefit. Is it the drug? Is it the double sequential? And he mentioned we'll be seeing the results of dose VF shortly, and then I came and gave the talk. So I think esmolol, I'm a fan of esmolol in the observational work. I'm not sure how it plays in, but I think esmolol has a role. Obviously, it'll need to be likely a randomized trial that shows its benefit to actually put it into practice. But I am a fan, and we've seen cases where both have been used and have been successful. Why? That's the issue. Who knows? Is it double sequential or is it the esmolol?
Hey, Shel, one question, I'll ask you this later so you can bring it up, is that do you feel like you have to stick with the results of your study, like how you did your protocol, or would you move earlier to, to an earlier shock, like after 2 or something like that, right?
So here's the thing you need to be careful about talking about doing it earlier. When you think about standard defibrillation, you need to look at survival rates after 1, 2, or 3 shocks. And survival rates after 1, 2, or 3 shocks are actually much better than 4 to 10. So Holman and the group in Sweden, they showed your survival from shocks 1 to 3 is about 30%, 4 to 10, it's about 12%, which is bang on what we got. And after 10 shocks, you're at about 4%. So if you say, I want to do this first, what you've got to show is that your survival is going to be better than 60%. I think that's a high bar to cross. And again, when you're talking about getting onto a patient's chest and doing CPR, doing double sequential right off is a little bit trickier than just putting on the standard AL pad. So to me, I think standard AL defibrillation is probably okay in those first 3 shocks. After that, though, to me, all bets are off. I think there are better strategies now than doing standard AL defibrillation after that. So that's why I'm a bit reticent to say earlier, unless I can prove moving double sequential makes that significant improvement.
I just want to make sure we were thinking about that. And then, and the other thing is, though, I am definitely moving towards, especially if we're going to put somebody on one of the machines or whatever, is to move to that earlier. Get the pad on the back. That kind of
yes.
thing.
Yeah.
I think
so. Shel, are you opposed to AP first, the vector change first?
So it's interesting that you mentioned that, because I learned this from you guys. Okay, I learned from the Florida group that they have people doing double sequential with the pads and AP first, and then it's easier to put on the AL pads after. I'm not opposed to it. It's just not what we did in the study, so I don't know if the results would be any different. But I'm big on choreography. I'm big on whatever is easiest for the paramedics. If that's easier, that's great. We do have video. People seem to really flock to the videos in New England that we sent. Now, we have video of how to do double sequential using mechanical CPR that we're going to release, because I think a lot of people have that question. But again, that's with standard AL first. So we have a mechanism, a way to do it. And we're going to release those videos shortly, because I think it's an area of big interest.
And then last but not least, let's go to
the Eagles meeting.
Yeah.
So the Eagles meeting. Can you come on in a half an hour then?
Yeah, I have the link, Paul. I'll come on. And do you wish me to give the same talk, Paul?
Yeah, sure. That'd be great. Okay. So thank you.
You're welcome. See you then.
Welcome to start.
Thanks,
come
Paul.
on with the meeting right away and see what we do. I think it'd be good to get to know the group. It'll be good for you. All right. And I want to thank Mike Feldman and all the other folks that were just fantastic up in Toronto helping us with the show last week. So thank you so much. See you later. Take care.
Thanks,
You're welcome. Well, thank you.
Let me bring in Dr. Mitch Malfair from the west coast of Florida. Mitch, I know you had a question, and then we'll go to Paul's webinar.
Winter Park. Hey, do you get any defibrillator manufacturers able to build a device for you?
Yeah, we haven't done that yet. I've had a lot of questions from the defibrillator manufacturers. I think we've, listen, to me, what would be perfect? What would be perfect would be a single defibrillator with 4 pads, and perhaps the defibrillation shocks being able to be delivered exactly like in the animal model. Who knows? Maybe this is just the edge of the iceberg. Maybe we can even do better with optimized defibrillation. So I think you're going to likely see changes. What those are going to be, I have no idea. But I think people are always asking about this now. Will there be changes in defibrillator? I leave that to the manufacturers.
What about an internal defibrillator probe, basically an esophageal probe that defibrillates from, internally, essentially. Would that be better because of the location, or that's too
Yeah.
hard to do in EMS anyway?
Yeah, to me, I don't have enough experience with that, so I wouldn't be able to
Yeah.
comment.
Wow. Well, I'll tell you what, it's not often that you get folks in EMS who are publishing in the New England Journal, and this was big, and you put a lot of your life's work into it. The paper is very easy to read. I mean, it's very well written. All the data is there. Thanks for giving us some of the background inside baseball on the slides that you didn't show anybody else. We appreciate that. And we look forward to hearing you back on the Pepe show. So we'll stop here and we'll all pop over to Pepe. And Shell, man, you're the best. Thank you so much for doing
Thank
this.
you. It really, thanks to the Florida group. You guys have been fantastic. I've always loved presenting to you folks. I think you're very progressive. You do some fantastic pre-hospital work. I think you've always been supporters of double sequential. And I said this, I'll just give you one last word. People ask me, are the guidelines going to change now? Do you know what I mean? And to me, guideline change is up to ILCOR, ERC, all these other people. And to me, I've always been taught, do your best science and let that science speak for itself. In the area of double sequential, in my mind, there's no better science than what we've done. The other science is just not the quality of what we've done in this randomized trial. So for those people who've already been doing double sequential without the strong science, hey, you can feel like, hey, you know what, we knew this was, we're seeing what we're seeing in our systems. It's now good to have some science to back us. So I think that's the important thing. I think, I know during this trial, we must have had 75 to 100 agencies contact me about double sequential, and they were already doing it. They wanted to know ways to do it better. So it's already out there. Regardless of what the guideline bodies say, people are already doing this. At least now there's a little better evidence for it.
And that's what I'm hoping that today's webinar and today's talk will accomplish here in the state of Florida, is that we in Florida do things that the AHA probably won't agree with until 2032. So we ought to have a body in EMS that has our own guidelines rather than waiting for the tablets to come down from the mountain of the ICU doctor. So you helped us do that, and Shell, thank you so much. Appreciate you.
Always a pleasure, Peter. Thank you to everyone. I'll see you on the Eagle. You're on.
Yeah, see you on the other side. Yeah.
Okay,
And,
bye.
thank you, Angus. We appreciate that, and we'll pop on over. So everyone, stick around, and we'll be on the Eagles in a minute.